Hi everyone, and welcome to our module on acute heart failure. One way to think about heart failure is to divide it up into an acute phase and a chronic phase, and this distinction is very important for understanding how we treat heart failure because the treatments for acute heart failure are entirely different from the treatments for chronic heart failure. So patients who have acute heart failure have symptoms from fluid overload. They are congested and swollen. They have pulmonary edema and shortness of breath. They have pitting edema. On physical exam, their jugular venous pressure is elevated, and many times these patients need to come in the hospital for therapy of acute heart failure, and that's what we're going to talk about in this video. Now, after patients have been treated for acute heart failure, they feel better. They are euvolemic on physical exam, meaning there are no more signs of swelling. They have clear lungs, no pitting edema, and their jugular venous pressure is flat or normal. They're still sick, however. There's lots and lots of studies showing that these patients are at great risk for dying from heart failure or from having their heart failure become worse over time. So in a separate video, I talk about all the therapies we use for chronic heart failure. But in this video, we're going to focus on how you treat patients who are acutely ill with heart failure and suffering from signs of fluid congestion. So first of all, let's talk about why patients develop an acute exacerbation of heart failure. The number one cause is dietary indiscretion. When patients consume high amounts of salt, like if patients eat fast food, like hamburgers and French fries, they will develop congestion, and I'll talk about why that happens on the next slide. The number two reason is poor medication compliance. The number of pills that patients with heart failure have to take are extensive. Many patients have to take 5, 10, or more pills per day. Often they don't understand their medicines and they skip dosages, and then they can develop an acute exacerbation of their illness. So to understand why dietary indiscretion and excess sodium intake leads to an exacerbation of heart failure, you have to appreciate that the body has many mechanisms in place to maintain the plasma sodium level at 140 milliequivalents per liter. Sodium is a very important osmole, so the body tightly controls its concentration in the plasma. What this means is when you consume extra sodium and you increase the plasma osmolarity, the body will respond. It will respond by releasing ADH. This will trigger the kidneys to hold on to free water, and that free water will balance out the sodium and maintain the plasma sodium concentration at a normal level, about 140 milliequivalents. The cost of this, however, is that the patient will have more volume. They will have retained fluid, and their volume will be up. Now, over time, they will dial down the renin-angiotensin-aldosterone system and dial down the ADH, and there will be more urine output, and this volume will be relieved. But in patients with heart failure, this transient rise in volume can be very dangerous. This can put them into pulmonary edema and wind them up in the hospital. And this is why high salt intake in patients with heart failure is very dangerous. And in my field of cardiology, we spend a lot of time counseling patients on how to avoid excess sodium intake. Some other causes of acute exacerbations are listed on this slide. Infection or trauma or surgery can all activate the sympathetic nervous system. This leads to the retention of sodium in water, and that can lead to an acute exacerbation of heart failure. Ischemia is a rare cause, but if the myocardium is ischemic, this can decrease the cardiac output and lead to a heart failure exacerbation. And then finally, one cause of acute exacerbations that is high yield for you to know for your boards is NSAIDs. NSAIDs are non-steroidal anti-inflammatory drugs. These drugs inhibit the enzyme cyclooxygenase, or COX, which is important for synthesis of prostaglandins. So when you inhibit COX, there are less prostaglandins in the body. And prostaglandins are very important for maintaining renal perfusion. So the result of taking NSAIDs is less renal perfusion and more salt and water retention by the body. And taking high dosages of NSAIDs, for example, to treat arthritis, is a classic cause of an acute exacerbation of heart failure. So now let's talk about therapy for acute heart failure. First of all, you should know that acute heart failure is often treated in the hospital, not always, but often. And when you do clinic rotations, especially in cardiology or internal medicine, you will often treat patients in the hospital for acute exacerbations of heart failure. The second thing you should know is that the main goal here is symptom relief. We want to relieve the congestion so that the patient breathes easier and feels better. And this is in contrast to treating chronic heart failure. There, the patient already feels better, so the goal is not to improve how they feel. The goal is to reduce the mortality rate and the hospitalization rate for a patient with chronic heart failure. And then the final thing you should be aware of in acute heart failure is that in most cases, the therapies are the same for diastolic and systolic heart failure. In both diastolic or systolic heart failure, the lungs are congested and patients feel short of breath, and the treatment is basically to remove that fluid from the body. There are a few exceptions, but in many cases, the treatments are the same. So the mainstay of treating acute heart failure, whether it is systolic or diastolic, is through the use of loop diuretics. I talk about these drugs in greater detail in the renal video on diuretics, but by way of review, These drugs inhibit the sodium-potassium 2-chloride pump in the ascending limb of the loop of Henle. They produce a very vigorous urine output, and therefore they're good in edematous states like heart failure and also cirrhosis. The major loop diuretics are furosemide, bumetanide, torsemide, and ethacrynic acid. All of these drugs inhibit the sodium-potassium chloride pump I mentioned on the last slide. This results in salt and water excretion and relieves congestion. The IV versions of these drugs in general are better than the oral versions of these drugs in acute heart failure because the patients often have a gut that is swollen and poorly absorbs oral medications. The key side effects, which I discuss in greater detail in the renal section, are hypokalemia and also volume depletion. These drugs can over-diurese someone and remove too much fluid, and that can lead to renal failure and hypotension. And then finally, all of these drugs are sulfonamide drugs except ethacrynic acid, and therefore in patients with a sulfonamide allergy, this can potentially produce an allergic reaction. It's super high yield to understand the hemodynamic consequences of administering loop diuretics, so let's talk about that now. Loop diuretics remove volume from the body, and that's going to lower the left atrial pressure. And this is very beneficial in patients with heart failure because high left atrial pressure is what causes pulmonary edema and dyspnea and many of the clinical features of heart failure. So by lowering the left atrial pressure, loop diuretics lead to improved symptoms in heart failure patients. But at the same time, the left atrial pressure is a marker of preload, and so by removing volume from the body, loop diuretics reduce the preload, and that reduces the cardiac output. Now this may seem crazy that we give a drug to heart failure patients that reduces the cardiac output, and yet this is done all the time. And the reason is because the cardiac output decrease is small, but the drop in left atrial pressure is very beneficial to patients. And then when the cardiac output falls, that's going to lead to activation of the sympathetic nervous system and the RAS, and there will be increased peripheral resistance. So what happens when you give loop diuretics is you actually amplify the negative hemodynamic consequences of heart failure. You lower the cardiac output and you further activate the sympathetic nervous system and the RAS. It turns out, however, that most heart failure patients can tolerate these effects. The drop in cardiac output is usually relatively modest, and the patients like that they feel better from lower left atrial pressure, and they don't get too sick from the drop in cardiac output. There are, however, some patients with severe end-stage heart failure who develop hypotension when you give them loop diuretics. In these patients, their cardiac output is very, very low from severe end-stage heart failure, and they can't tolerate the fall in cardiac output associated with loop diuretics. Make sure you understand everything I've written on this slide. I can't emphasize to you how important it is to understand these hemodynamic changes that occur when you administer a loop diuretic and remove volume from the body. Metolazone is a thiazide-like diuretic. It functions like a thiazide diuretic on the nephron, but it has a slightly different chemical structure from thiazides. Therefore, it's called a thiazide-like drug. But just like all thiazide diuretics, it inhibits sodium and chloride reabsorption in the distal tubule. And metolazone can be given together with loop diuretics in acute heart failure to give the loop diuretic drug a kick. The idea here is that when a loop diuretic inhibits sodium reabsorption in the ascending limb of the loop of Henle, sodium is delivered distally to the nephron. Some of that sodium is reabsorbed in the distal nephron, and this blunts the effect of the loop diuretic. If you also inhibit sodium reabsorption here, then you get a 1-2 punch, and you send lots of sodium out in the urine. This produces a vigorous diuresis, and this can be helpful in patients with acute heart failure. The side effects are the same side effects as you see with loop diuretics. Additional fluid can be lost and additional potassium can be lost by giving the two drugs together. Nitrates are another drug class that can be used to treat acute heart failure. The predominant mechanism of nitrates is venous dilation. The veins become dilated and bigger veins hold more blood. This pulls blood away from the left ventricle and lowers the left ventricular end diastolic volume, which is the preload. This will lead to a lowering of the left atrial pressure, and this will lead to less pulmonary edema and improved symptoms of dyspnea. Nitrates do not help remove the fluid from a patient with heart failure, but they move the fluid away from the lungs so that patients feel better. The side effects of nitrates are shown on this slide. They're all related to vasodilation in places other than the veins. So vasodilation in the meninges can cause a headache, which can be a bothersome side effect. The skin can vasodilate, and this can cause flushing, and then the blood pressure can fall from lowering the preload to the left ventricle and from systemic vasodilation, and this can lead to hypotension. Another group of drugs that are sometimes used in acute heart failure are vasodilators. This is called afterload reduction. So drugs like ACE inhibitors and hydralazine cause peripheral vasodilation. This reduces the afterload on the left ventricle and can potentially increase the cardiac output and improve symptoms. So especially in patients with acute heart failure who have very high blood pressure, giving vasodilators and lowering the afterload can help improve symptoms. Nitrates and hydralazine are a special combination that is sometimes used for both acute and chronic heart failure. These two drugs together have been studied in systolic heart failure patients, and the idea here is to reduce the preload with nitrates and reduce the afterload with hydralazine. Acutely, this therapy is sometimes used to improve symptoms, especially in patients who are very hypertensive. And chronically, this therapy has been shown in a few studies to lower mortality among patients with chronic systolic heart failure. Now, in the modern era, this combination has largely been replaced by ACE inhibitors, but this combination is still sometimes used. For the remainder of this module, I'm going to talk about inotropes. Inotropes are drugs that increase myocardial contractility. So as you can imagine, these drugs are only useful in systolic heart failure where myocardial contractility is reduced. They have no role in diastolic heart failure where contractility is normal. All of these drugs activate the beta-1 pathways in myocytes in one manner or another. We'll talk about that in a little bit. This means that they will generally increase the heart rate and also the contractility, and because they increase heart rate and contractility, they will raise the cardiac output, and that's helpful in systolic heart failure. Now, these drugs can also, in many cases, activate beta-2 pathways in smooth muscle. Those pathways lead to vasodilation in the periphery, and therefore many of these drugs can also cause hypotension. The first inotrope we'll discuss is milrinone. Milrinone is a phosphodiesterase 3 inhibitor. In myocytes, phosphodiesterase 3 breaks down cyclic AMP, and cyclic AMP is important for myocyte contraction. So when you inhibit the breakdown of cyclic AMP, you raise the level of cyclic AMP in myocytes, and this leads to more contraction. I've shown this at the bottom of the screen. Normally, when beta-1 receptors are activated, they raise the level of cyclic AMP. Cyclic AMP is broken down by phosphodiesterase 3, so when you inhibit this, you will raise the level of cyclic AMP, and that leads to more contraction. Now, in vascular smooth muscle, the same thing will happen. There'll be a rise in cyclic AMP. This is part of the beta-2 receptor system, and this will lead to vasodilation. That means that in addition to increasing inotropy, these drugs also cause vasodilation and therefore can potentially cause hypotension. Milrinone is an IV drug. It's usually given by drip in the ICU. This is reserved for critically ill patients with advanced systolic heart failure. Our next inotrope is dobutamine. Dobutamine is mostly a beta-1 agonist, so therefore it will act on myocytes to raise the heart rate and contractility. It's also a weak beta-2 agonist, so therefore it can cause vasodilation. This means that just like milrinone, it can increase inotropy and contractility. It can also cause vasodilation and hypotension. And also, just like milrinone, this is an IV drug. It's usually given in an ICU under monitored conditions for advanced heart failure. The two main inotropes that are used in advanced heart failure are milrinone and dobutamine, but I'll also talk about two other drugs that can potentially be used as an inotrope. The first one is dopamine. So when dopamine is given intravenously, it does not cross the blood-brain barrier, so it has no central nervous system effects. And you may know that dopamine has many effects on the brain, but none of these are seen when the drug is given intravenously. Peripherally, the effects in the body are highly dose-dependent, so when you give a low dose of intravenous dopamine, the drug works as a dopamine agonist and causes vasodilation in the kidneys. At a medium dose, the drug is a beta-1 agonist and it will increase heart rate and contractility, and for this reason, dopamine is sometimes used as an inotrope. And then finally, if you give a very high dose of dopamine, it begins to have alpha agonist properties, and therefore it will cause vasoconstriction. And much like dopamine, epinephrine can also sometimes be given intravenously as an inotrope. It also, like dopamine, has dose-dependent effects. At lower dosages, epinephrine is a beta-1 and beta-2 agonist, and therefore it will raise the heart rate and increase the contractility and also cause vasodilation, much like milrinone and dobutamine. At higher dosages, epinephrine is an alpha agonist, and it will cause vasoconstriction. As I've mentioned, for all of these inotropes, they are given intravenously, usually in a monitored setting like an intensive care unit. The reason for this is because, first of all, they're given to patients who are very sick with heart failure, but also the drugs themselves carry significant risks. Numerous registries and clinical trials have demonstrated increased mortality with the routine use of inotropes. One of the major problems is that they stimulate the heart in a patient with a sick heart that is vulnerable to arrhythmias, so these drugs often cause ventricular and atrial arrhythmias. Sometimes they can even cause ventricular tachycardia and ventricular fibrillation. So the bottom line is that they're dangerous drugs that we reserve for only very sick patients who have a severely depressed cardiac output, and we usually administer them in the ICU under closely monitored conditions. So now that we've gone through all the drugs used for acute heart failure, let me show you a typical acute heart failure course in the hospital. This is something that you're going to see over and over again on your clinical rotations in third year. So a heart failure patient will present to the ER with dyspnea and edema. They may be sleeping in a chair because they're short of breath lying flat. They'll be admitted to the hospital for acute heart failure. They'll be given a nitro drip to relieve the dyspnea, an IV furosemide, or another loop diuretic to remove fluid. By hospital day 2, their weight is down 4 kilograms from diuresis and they feel better. The nitro drip is stopped, the loop diuretic is converted to an oral drug, and on hospital day 3, they are discharged. A more complex heart failure patient's course might look something like this: a similar ER presentation with dyspnea and edema and sleeping in a chair. Maybe the patient has a known severely reduced ejection fraction like 10%. This patient will be admitted to the hospital and given a nitro drip to relieve dyspnea and an IV loop diuretic to remove fluid. However, after a day or so, the patient has poor urine output, the extremities are cool, and the creatinine is rising, indicating underperfusion of the kidneys. At this point, an inotrope is indicated, so for example, dobutamine might be started as a drip in the ICU. After that, in the next few hospital days, there's good urine output, the weight falls, the breathing improves for the patient. By hospital day 6, the dobutamine can be stopped and the furosemide or loop diuretic can be stopped. On hospital day 7, an oral loop diuretic can be administered prior to discharge, and then the patient can be discharged home. I'll briefly mention an important quality of care topic called a heart failure readmission. Recurrence of heart failure after discharge is very common, so post-discharge follow-up for patients that leave the hospital after treatment for heart failure is very important. And readmissions, meaning a patient that leaves the hospital but returns for another admission within 30 days, are a focus of public health policy, and there's a very high risk of readmission to the hospital within 30 days for patients who are discharged after treatment for heart failure. In fact, among the Medicare population, this is the highest risk category, meaning if you leave the hospital after treatment for heart failure, you are in the highest risk. In other words, you are the most likely type of patient to be readmitted within 30 days, and therefore this is a target for many quality interventions. A few more words about acute heart failure. Most patients after discharge require a chronic daily dose of a diuretic. This helps to maintain the euvolemic status. Often it's oral furosemide or some other loop diuretic. And then some patients require a daily dose of a long-acting nitrate to help them feel well. Often this is oral isosorbate mononitrate, which is the long-acting form of nitroglycerin. And then there are rare patients who, even after the fluid is removed and they are decongested, they still are sick and require continued treatment for a low output state. This only occurs in systolic heart failure, but there are some advanced systolic heart failure patients who, even after diuresis, continue to feel fatigued and have cool extremities and low blood pressure. These patients are suffering from a very low cardiac output. There are a couple of options for these patients. One option is to send them home on a chronic IV infusion of an inotrope. This is called home dobutamine. Some patients can go home on a drip. These are also the type of patients where we use left ventricular assist devices or LVADs. These are mechanical hearts. And then finally, heart transplantation is an option for some of these patients. I'll finish this video by talking about digoxin. Digoxin is the only available oral inotrope. All the inotropes I talked about in this video are IV drugs usually administered as a drip in the ICU. And once upon a time, dig and diuretic was the mainstay of heart failure treatment, but this has changed. There are a couple of reasons for this. First of all, a number of clinical trials showed that digoxin had no mortality benefit. In fact, some had a signal of harm, so this made people hold back on using digoxin so frequently. In addition, digoxin is not effective for diastolic heart failure, and in the modern era, diastolic heart failure is about half of all cases. And then finally, digoxin carries significant risks of side effects, so for this reason it's also avoided whenever possible. So I talk about digoxin in more detail in the video on antiarrhythmic drugs, but I'll briefly review its effects here. Digoxin has two important cardiac effects. First of all, it inhibits the sodium-potassium ATPase pump in myocytes. This leads to more sodium inside the myocyte, which in turn leads to more calcium in the cell. And when there's more calcium in myocytes, there's more contractility. And this is the mechanism by which digoxin increases myocardial contractility and functions as an inotrope. It also has a completely separate effect on the heart. It suppresses AV node conduction by increasing parasympathetic activity to the heart. For this reason, it can sometimes be used to slow the heart rate in rapid atrial fibrillation. So when do we use digoxin in the treatment of heart failure? Well, first of all, it's only useful in systolic heart failure patients. We reserve this drug for patients who have symptoms despite maximal therapy on other drugs. For example, a patient who has persistent dyspnea despite a good volume status. It can be administered for acute heart failure in the hospital to increase contractility, but it's also more often used long-term in the outpatient setting to increase cardiac output and make patients with a low output state feel better. So shown on the screen are the benefits of digoxin that have been demonstrated in clinical studies. Digoxin can increase the cardiac output, it can improve symptoms and quality of life, but it has no established mortality benefit. In other words, it doesn't make the patient any less likely to die from their heart condition. And that concludes our video on acute heart failure.